We are live now, sir. Please start.
Good evening, all. A warm welcome to ExRxIndia's For the Students, by the Students web series. The last topic today from the students' IDs. Thoracic Outlet Syndrome will be presented by Ms. Vyas Nirali, Jigneshkumar from CM Patil College of Physiotherapy, Gandhinagar, Gujarat. I welcome ExRxIndia members Dr. Rupesh and Professor Duna. Now I welcome our resource person Vyas Nirali Jigneshkumar to present her topic. Vyas Nirali, please.
Yes, sir. Okay, sir. Hello, everyone. Good evening. I am Nirali Vyas from CM Patel College of Physiotherapy, KSV University, Gandhinagar, Gujarat. I am BPT third year student. I would like to thank Dr. Chandramohan sir, Dr. Rupesh sir, and Professor Dr. Duna ma'am to give me this opportunity to present my topic here. So today's my topic is thoracic outlet syndrome. Let's start. Okay, clinical anatomy. What is thoracic outlet? So thoracic outlet is area between the intervertebral foramina to lower border of axilla. Okay, it is also called as the cervico-thoracobrachial region. Now next, general boundaries of thoracic outlet. You can see in this figure that anteriorly this thoracic outlet is bounded by clavicle, pectoralis minor, subcoricoid process, and deltopectoral fascia. Posteriorly by upper trapezius and scapula. Medially, you can see in this figure scalenus anterior, scalenus medius, and scalenus posterior muscle, and laterally by axilla. Okay, now relations. The plexus entered the outlet between the scalenus anterior and medius muscle. You can see here that plexus entered into the outlet between the scalenus anterior and scalenus medius muscle. Now, subclavian artery runs posterior to scalenus anterior muscle, but subclavian vein runs anterior to scalenus anterior muscle. You can see here that artery runs posterior to scalenus anterior muscle, but subclavian vein runs anterior to scalenus anterior muscle. Okay, so there are only in interscalene triangle, only two structures are passed. That is a brachial plexus and second one is subclavian artery. Subclavian vein is not part of interscalene triangle. We will see it further later. Okay. Now, then the blood vessel join the brachial plexus and course together under the clavicle and over the first rib. You can see here under the clavicle and over the first rib. Then under the coracoid process and posterior to pectoralis minor muscle. Okay. Now, what is thoracic outlet syndrome? So the term thoracic outlet syndrome was originally coined in 1956 by RMP. Okay. Now, definition. So TOSS is defined as compression of neurovascular structures at thoracic outlet. You can see here in figure. Okay. But in thoracic outlet area, there are three sites for compression. First one is a scalene triangle. Second one is coastalclavicular space. And third one is subcoricoid space. Okay. We will see it later. Next. Now epidemiology. Age. Usually figures of the age. Gender. Female-male ratio is 3:1. Neurogenic toss 95 to 98% and vascular toss 2 to 4%. Now, causes of the toss. So, first one is congenital factors. Congenital means it is present from the birth. Okay. Now, which are that factors? So, cervical rib, elongated transverse process of C7 and any other congenital abnormality in thoracic outlet area. Okay. Now, second one is postural variation. Okay, if person is for longer period of time in faulty posture, then there is a development of upper cross syndrome. As the name suggests, upper means in upper quadrant of the body. Okay, and cross means it will follow the cross pattern. For example, in cross manner, muscle become a tight, and in other cross manner, the the structures become a weak. Okay. Now, for example, posterior superior structure, upper trapezius and levator scapulae are tight. Then opposite to that, uh, antero-inferior structure means pectoralis major and pectoralis minor. These muscles become a tight. And opposite to that cross, if antero-superior structure, deep neck flexors are weak, then opposite to that, posterior-inferior structure means serratus anterior, rhomboids, and lower trapezius. This muscle become a weak. Okay. Next. So third one is postural stress. As you can see in this figure, right? The person is carrying a heavy bag and that side shoulder is depressed. Okay. And because of this heavy weight, there is a more traction across the shoulder girdle tissue. Okay. Now next. Next is respiratory pattern. You can see here in this picture. Okay. Abnormal respiratory pattern. What happens if person has abnormal respiratory pattern? Then there is an overuse of accessory muscles. Okay. For example, if scalene muscle is overworking, then it will pull the first rib in upward direction, and it will lead to compression of the neurovascular structure in interscalene triangle and coastalclavicular space. Okay. Next, fifth one is traumatic injury. So you can see here in clavicle fracture. Okay. Then first rib fracture. You can see here first rib fracture, right? Okay. And whiplash injury. In traumatic injury, it will also affect it. Then hypertrophy of scalene muscle and pectoralis minor muscle. As I said you earlier, due to faulty posture, pectoralis minor muscle is affected, and it is also accessory muscle. If it overworking, then the hypertrophy may be developed of scalene muscle and pectoralis minor muscle due to abnormal respiratory breathing pattern. Then seventh is other occupying space lesion. Okay, any malignancy around the breast, or if malignancy is in upper apical area of lung. Okay. Next, am I audible properly?
Yeah, you
You
are
are
audible.
audible. Please carry on.
Okay. Now, further types of toss. Okay, there are two types of toss mainly. First one is neurological toss and second one is vascular toss. In neurological toss, there are again two: neurogenic toss and non-specific symptomatic toss. Then in vascular toss, there are again two types: arterial toss and venous toss. Okay, let's see further. Okay, now how you will diagnose the neurogenic toss? So these symptoms are present in following symptoms are present in neurogenic toss. Okay, paresthesia, pain in shoulder, arm, forearm, and fingers. Okay, then occipital headache is there due to tight scalene muscle. This will refer from tight scalene muscle. Then weakness of arm, forearm, and hand. Now next. So in neurogenic toss, there are again two: non-specific toss or upper toss. Why? Because it will include the upper nerve root C5, C6, and C7 in interscalene triangle specifically. Okay. So the signs and symptoms you can see: because of nerve root compression, dermatomal and martomal pattern may be followed. Then second is true neurogenic toss or lower toss. Why lower toss? Because it will include the lower nerve root C8 and T1 is compressed in coastalclavicular space. Okay, remember this always, that toss does not follow the dermatome or martome pattern unless there is a nerve root involvement. Means if there is a nerve root is involved, then and then only it will follow the dermatomal and martomal pattern. Otherwise, diffuse type of pain is seen. Okay. Next, second is vascular toss. In vascular toss, There are two, arterial toss and venous toss. In arterial toss, how you will diagnose? So that is a in arterial toss. So how you will diagnose it? So if subclavian artery is compressed, then what happened? There is a loss of peripheral pulse, coldness, then pallor, fatigue, weakness, ischemic type of pain, and Raynaud's phenomena due to lack of arterial blood supply. Next, second is venous toss. Why? So how you will diagnose the venous toss? So for venous toss, following symptoms are there. So if the subclavian vein, you can see here in picture that if subclavian vein is compressed, then there is a peripheral pooling of the blood, and because of that the part become a warmth, edema is there, venous distension you can see, then cyanosis means bluish discoloration of skin and sclera due to lack of blood due to lack of oxygenated blood supply. Then thrombosis may be occurred due to repetitive use of the arm. Next, which are the sites of compression? There are three sites for compression. First one is Scalene triangle, second is Coastalclavicular space, and third one is Subcoricoid space. Now, let's see. So, first one is Scalene triangle. So, as the name suggests, Scalene triangle. So, it is formed by scalene muscle and first rib. So, boundaries. So, you can see here in figure that anteriorly it is formed by scalenus anterior, posteriorly by scalenus medius, and inferiorly by first rib. Okay. Which are the contents of scalene triangle? There are two contents, brachial plexus and subclavian artery. Why vein is not? Because we had seen earlier that subclavian vein runs anterior to scalenus anterior muscle. Okay, so it is a not part of scalene triangle. The signs and symptoms we had seen earlier, which structure is compressed, according to that signs and symptoms we can see. Okay, now second, coastoclavicular space. Costo means rib, clavicle, between clavicle and first rib, the space that is known as coastoclavicular space. Now boundaries. So anteriorly middle third of clavicle, posterior-medially by first rib, and posterior-laterally by upper border of scapula. Now contents. There are three contents: middle part of brachial plexus, subclavian artery, and subclavian vein. Again, which structure is affected or compressed, according to that signs and symptoms you can see that we had discussed earlier. Then third one is subcoricoid space. Sub means below the coracoid process, the space, it is known as a subcoricoid space, and the other name is the retropectoralis minor space. Why? Retro means behind the pectoralis minor, that is known as retropectoralis minor space. Okay, so now boundaries: anteriorly pectoralis minor and deltopectoral fascia, posteriorly by 2 to 4 rib, and superiorly by coracoid process. Again, contents. So lower part of brachial plexus, subclavian artery, and subclavian vein. Which structure is compressed, according to that signs and symptoms you can see. Okay. Now, when symptoms are aggravated, so if we palpate the scalene muscle in scalene triangle, then also the symptoms may aggravate. Then Adson's maneuver. What happens in Adson's maneuver? When we stretch the scalene muscle, there is a it will place the tension on upper part of brachial plexus and subclavian artery. Okay, subclavian vein is not part of interscalene triangle, so it will not affect it. Now, second, if clavicle is depressed for long period of time, as we had seen earlier, that person is carrying a heavy bag, at that side shoulder is depressed and there is a traction on the shoulder girdle tissue. Okay, then it is also with faulty slouch posture. What happens in faulty slouch posture? So in faulty slouch posture, there is a rounded shoulder, then there is an anterior tipping of scapula and forward head. Due to this, the space is reduced. Coastalclavicular space and the thoracic outlet space is reduced. Okay. Then in case of upper thoracic breathing with the patient of asthma and COPD, and it may be present also in normal person who are doing the chest breathing. Okay. Now, what this all leads to cause narrow of the coastoclavicular space. Now, if the compression is in coastoclavicular space, then miliary breath test will locate the patient symptoms. Now, the other. So, activities like abduction and external rotation of the arm. As we can see in sports person who is a throw baller or tennis player or swimmer, in that there is a repetition of abduction and external rotation of the arm, and any other occupation in which abduction and external rotation is there, what happens if abduction and external rotation of arm is more? So it will stretch the lower part of brachial plexus and blood vessels. Okay. Now, palpation pressure against pectoralis minor will reproduce the patient's symptom. Okay. If the compression is in subcoricoid space, then Ruse test will provocate the patient's symptom. Okay. Now, we'll go for special tests. Okay. In special tests, first one is Adson's maneuver. So this test is probably one of the most common methods of testing for thoracic outlet syndrome quoted in literature. So what we have to do in this test, first the examiner will locate the radial pulse, then the patient's head is rotated towards his shoulder. Okay, if I am checking right side, then patient head is rotated towards right side. Okay, then patient extend the head while the examiner will laterally rotate and extend the patient's shoulder. Okay, and the patient is instructed to take a deep breath and hold it. A disappear of pulse indicate the positive test. Okay, you can see in figure here. Okay, Adson's maneuver. What we had done in this, examiner will palpate the radial pulse, then ask the patient to rotate at that side head, then the therapist will extend and laterally rotate the arm. At that time, the patient extend the head. Okay. Now, and ask the patient to hold the deep breath and hold it. If there is a disappear of the pulse, then the test is positive. Okay. Then Coastalclavicular Syndrome or miliary breath test. Okay. What we have to do in this test? So in this test, the examiner will palpate the radial pulse, then draws the patient shoulder down and back. So in this procedure, we had seen earlier that if person is carrying a heavy bag, then the shoulder is depressed. But in this maneuver, what we are doing? We are manually down the patient's shoulder. Okay. So the space, coastoclavicular space is reduced. Okay. The test is indicated by absence of radial pulse and implies possible thoracic outlet syndrome, coastoclavicular syndrome. Okay, this test is particularly effective in patients who is complain of symptoms while wearing a backpack or a heavy coat. Okay, you can see here what we see in this test. Okay, you can see here the examiner will palpate the radial pulse and extend and draws the patient shoulder downward direction. Okay, so it will compress the neurovascular structures in coastoclavicular triangle. Now, Halstead maneuver. The examiner will find the radial pulse and applies the downward traction on that extremity while the patient's neck is hyperextended and head is rotated opposite side. For example, I am checking right side, Then patient head is in opposite side rotated and extended. Okay. Absence of and disappear of the pulse indicate the positive test for thoracic outlet syndrome. You can see here Halstead maneuver. Okay. The therapist will palpate the radial pulse, then ask the patient to rotate the head opposite side and extend that side. Okay. And if there is a dis and the therapist will draws the shoulder downward direction. If there is a disappear of the pulse, then the test is positive for thoracic outlet syndrome. Now further this is a Ruse test. Okay. The starting position of Ruse test is this: 90-degree abduction of shoulder joint, 90-degree flexion of elbow joint. Okay. And ask the patient like this and ask the patient to laterally rotate the arm. Okay. Then ask the patient open and close your hand slowly for 3 minutes. Okay. If there is a patient is unable to keep the arm position in starting position for 3 minutes or suffer from ischemic pain, heaviness or profound weakness of the arm or tingling numbness of the hand, then the test is considered as positive as a thoracic outlet syndrome. So as we had seen earlier that abduction and external rotation will tension on the lower part of brachial plexus, okay, and blood vessels. The minor fatigue and distress are considered as negative test. The test is sometimes called as positive abduction and external rotation position test, hands up test, elevated stress test. Okay. Next. So what we had seen, these all Edison's maneuver, Coastalclavicular Syndrome, Halstead maneuver, and Ruse test. These all will aggravate the patient's symptoms. Okay. And only this one test will relieve the patient's symptoms. Okay. Shoulder girdle passive elevation test. If patient is come with already signs and symptoms with you at that present moment, then you have to do this test. Okay. The patient sits and the examiner will grasp the patient arm from behind. Okay. And like this, you can see your figure in first one. Okay. Like this, hand place of the therapist. Then what the therapist will do? Passively elevate shoulder girdle up and forward, okay, into full elevation. The position is held for 30 or more seconds. Arterial relief is evidenced by stronger pulse, skin color changes, increased hand temperature. We had seen earlier that if arterial involvement is there, then there is a disappear of pulse, pallor is there, pulselessness is there, then hand temperature is decreased and nude phenomena is there. Okay. All are relieved by this test by stronger pulse, skin changes, more pink, and increased hand temperature. Venous relief. We had seen earlier if the subclavian vein is involved, then what happens if subclavian vein is involved? There is the part is warm, then cyanosis is there, venous distension is there, okay, and any other symptoms are of veins. So you can see if by this test venous relief is there is a decrease of cyanosis and venous engorgement. Then neurological signs go from numbness to pins and needles or tingling, as well as some pain as ischemia to nerve is released. This is referred as release phenomena. Why release phenomena? Because all these symptoms will relieve. Okay. Now let's go for diagnostic image. The diagnostic image will done for differential diagnosis. Okay. You can see in this figure that cervical rib is here, right? You can see here in this picture also there is a presence of cervical rib. So it will compress the neurovascular structure in scalene triangle and coastalclavicular space. Okay. Then next, this is a chest X-ray. Now the cervical spine X-ray, you can see here elongated C7 transverse process. Okay, the cervical spine X-ray is also done to differentially diagnose the cervical spondylosis, and shoulder X-ray is also done to differentiate any other conditions. Okay, now MRI and CT scan is also done to rule out the cervical myelopathy and PIVD. Okay, then USG color Doppler. This is used for to know the vascular status. If there is any occlusion is there or stenosis is there, you can able to know by this. Okay. Now next, MR angiography. In MR angiography, there is an extrinsic compression. Oh, you can observe the extrinsic compression. Okay. Now next. EMG NCV. EMG NCV is done to know the to rule out the any other condition like a CTES or cubital tunnel syndrome and any other peripheral nerve related lesion. Okay, now I will explain the treatment in not going too much detail in that, but in treatment portion there are two: conservative treatment and surgical treatment. In conservative treatment, there is first one is pharmacological treatment. In that, NSAIDs, anticoagulant is given to the patient, and that is given to the patient. Then muscle relaxants are also given, and then physiotherapy. In physiotherapy, as we had seen in earlier, that if there is an abnormal breathing pattern, so in that patient we have to correct the breathing pattern by breathing exercise, for example diaphragmatic breathing, and any other related to that condition we have to educate the patient. Okay, now then postural correction exercises. Then ask the patient to do the ergonomical changes. Okay. Then in surgical treatment, what we have to do in surgical treatment, scalenotomy, then excision of the first rib, or if any bony abnormality is there, then excision of that part. Okay. Now and if vessels are involved, then angioplasty or angioplasty. Okay. Any questions? I will again thank you, Dr. Chandramohan sir, Dr. Rupesh sir, Dr. Duna ma'am, my college principal sir, my faculties, my mentor, and my friends and my family members also. Thank you. I'm concluding it here.
Thank you so much. It was a nice presentation, Vyas Nirali. And we would like to take this opportunity to thank your principal.
Thank you, Nirali. It was really very nice presentation from you. Yeah, can you hear me? Can you hear me now? Yeah,
can you hear me? Am I audible?
I can hear you. Yes, you are. Hello?
Okay. My session is complete, ma'am.
Yes, very nice presentation from you. And I would like to thank you and your family members and your teachers, whoever guided you.
Yes, it's completed.
Yeah. Thank you, and thank you everyone. You have got lots of
I cannot hear
appreciations.
you. Your voice is breaking.
Okay. Chandramohan sir, can you hear me?
Yes, it's clear, madam. Just you continue, say thank you, then we will message her. No need to.
Okay. Thanks to everyone.
Hello.
And I would like to conclude
Any
here and
questions,
bye-bye.
participants?